In this video, we are discussing why stretching, like this, isn't going to solve the root problem of your calf tightness. What's up, guys? My name is Dr. Brian Larish, and I am the owner of Performance Redefined, a cash-based PT clinic, as well as the creator of the PT Growth Academy, where we strive to raise the standards of the physical therapy profession. Now, in this video, we are talking about how to truly solve the root problem of calf tightness. And by the end of this video, you will learn how to understand and differentiate between the symptom versus the source, understand how to identify the source of the problem during your assessment, and then we're going to walk through an example as to if I were working with a patient with chronic tight calves, some of the mindsets, the frameworks, and the exercises that I would give to them. So with that being said, let's jump in. So the very first thing we need to do is make sure we're in the right mindset. And we do that by understanding the difference between the symptom and the source. The symptom of calf tightness is just that. It's the calves. The source of tight calves is the center of mass. What we're dealing with here is a center of mass dysfunction. The dysfunctional center of mass is creating a position, a posture, a pattern where this individual, the one with tight calves, has no choice but to have tight calves. So if we don't change the center of mass and we just stretch the calves, we're not creating any sort of change. We're not chipping away at the root problem. And so we have a scenario where we stretch the calves, we feel a little bit better because we increase blood flow, but it doesn't do anything long term. And that person that's stretching calves is the same person that's stretching calves 5 years from now, 10 years from now, chronically. Now let's talk about this center of mass issue. Take a second, stand up if you can. And what I want you to do is to anteriorly tip your pelvis. So that's arching your back. And I want you to start to recognize what happens as you do that. Do you feel more pressure in your toes or do you feel more pressure in your heels? If you did it right, you should feel more pressure in the toes. You should also feel the calves start to tighten up. Why? Well, if we are in an anterior center of mass where we're pushed forwards, the calves are like a reins on a horse pulling back. So just from the center of mass, they have to be on. And this is why so many people with tight calves have hypertrophied or enlarged calves. You may look at them and say, damn, they have big calves. How do I get my calves like that? Well, their center of mass is forward, so they're always being worked because they're toe walking. And that's the other thing when it comes to a center of mass that's moving forward in tight calves. Usually you can watch them walk and you see that distinct toe walking. Why? Because as they shift forward, their heel is struggling to hit the ground. And over time, they start to learn how to stay up on those toes, the calves stay on longer, and it just spirals into this chronic tight calf scenario. So as we move forward, really understand the symptom is the calf. We can put a Band-Aid on a symptom and make it feel better short term, but if we want long-term success, we have to start to change the center of mass. So now we understand what we are going against. Not tight calves, but a dysfunctional center of mass. Now we need to understand how to identify when someone is in this anterior center of mass. Now a quick disclaimer, an anterior center of mass is not always a bad thing. It's a bad thing when it becomes a bad thing, right? When it's part of your patient's dysfunction. So in a second, we're going to start to look at our assessment as it correlates to movement with our anterior center of mass. But first, let's talk about the subjective exam. There's two things I want to raise your awareness on. The first one, I know it's going to sound really groundbreaking, and that is when the person comes in and says, I have tight calves. Really easy, I know, but at least you can start to get the gears turning and start increasing your awareness as to, are they in this position that's causing that? The second thing that a lot of people will say is that they walk on their toes, that they have a really bouncy gait. I don't know why I walk like this, but Every time I walk, I feel like I'm bouncing. I feel like my heel doesn't touch the ground. These are all words that are telling you that they are pushed forwards. So pretty easy, but two things to consider during your subjective exam. Next, we want to look at their posture, their pattern, and their shin angle. So from a postural standpoint, what we want to really think about is that when someone is in an anterior center of mass, they're usually going to have a rib cage that is flared up. They're usually going to have an increased lumbar lordosis. They're usually going to have an anterior pelvic tilt. So from an exaggerated standpoint, it would look like this. Now, as it relates to the shin angle, we want to take a look, ideally not really tell them because then people start to change how they're postured and how they're standing. But what we want to consider with the shin angle is, are they negative, neutral, or positive? Negative, slightly behind or hyperextended as it relates to the ankle. Neutral, right over the ankle. And positive, slightly forward. A lot of times what you're going to see is a positive shin angle or an angle that looks like it's pushing forwards. So consider these factors as another confirmation that the person is moving forwards. Next, we want to look at our actual range of motion to determine an anterior center of mass. There's two key things that will really be apparent. The first is that when someone has an anterior center of mass, they usually have limited hip external rotation on both sides of the body. They typically lose external rotation on both sides. Next, they may or may not have this on both sides, but in general, they're going to have limited hip flexion. So hip flexion limited. And one quick bonus, when someone's in an anterior pelvic tilt, it actually allows them to increase their internal rotation. However, if someone is really tight or patterned, they will start to lose that as well. So just think of that as something to keep in the back of your head. But remember, bilateral loss of hip external rotation, bilateral loss of hip flexion, these are more clues that this person's in an anterior center of mass. So up to this point, we're aware of the source versus the symptom, as well as different pieces of information we can gather to identify if they're in an anterior center of mass. Now I want to walk through 4 exercises as an example as to what I would genuinely do with someone that has this problem. Now, I don't want you to get crazy focused on the actual exercise. Instead, it's the principles of the exercise. And in all honesty, at this point, you should understand the principles. We want to get the person to move back. We want to change their center of mass. When we start to shift someone back, it automatically takes that tension off the calves. Why? Because they're shifted forward. The calves are the reins on the horse. When we come back, we remove that. So we're in a different starting position. So the first exercise I like to do is have them go into a 90-90 position and just work on them bending the knees to get a little bit of a posterior pelvic tilt. As we go into that posterior pelvic tilt, it's already starting to shift my center of mass back. I am then going to add a protraction to get the rib cage down, and then we're going to breathe. We need to get this person comfortable and familiar breathing with more of a posterior center of mass. All these things we're doing are just giving them reference and constraints to be successful. So when you put it together, bend the knees, tuck the tailbone, push away from the wall, slight protraction, head stays nice and relaxed, and then we're just getting them to breathe. Inhale through the nose, exhale through the mouth. If they can't get in this position because they're already complaining of tight calves, add a slant board in, and that way it can help create a posterior weight shift with a little bit more space. Next, we're going to go to the classic half kneeling wall ankle mobility. What we're thinking about here is, yes, all the things that we typically do where we're bringing the knee to the wall, where the heel must stay down, so the patient will have to figure out where that is. But there's one key aspect that is always neglected when this exercise is performed. And if I just go through this, in this position, can you tell what the problem is? It's not my heel. My heel is down. I feel a stretch. Great. But we are forward. Our center of mass is forward. This is a great exercise to do all the things it does, but it's even better to teach the person how to dissociate from the knee, essentially. Meaning, as the knee pushes forwards, they need to know how to stay back, not by extending back, but by truly owning that position. And when you do it right, there's this sense of dissociation. The knee goes forward, but the body stays. A person that has chronic tight calves doesn't understand what that feels like because everything is forward and they don't ever really get to feel the hip staying back as something. The knee, in this example, goes forward. So as you go through this drill, the goal is stay nice and strong with the arms. So you have almost a slight posterior direction here, slight protraction, and the knee goes forwards without the body. So they should stay pretty upright. They still should feel a stretch, but really cue them in on the awareness component. Next, we're going to a front foot elevated split squat. Now this exercise does a lot. Elevating the front foot automatically pushes and biases weight back. That's number one. Number two, it's an easy way to increase awareness of the dissociation of the knee compared to the body. So we're really trying to get the patient to understand how to move the knee without moving the body. This can be done on the wall, as I'm going to show you, but it can also be done off the wall. The thing is, when patients do it off the wall, the back leg tends to mess up. So what we're looking for at the back leg is the knee to move straight down like an elevator. And the goal here is to go from a negative shin angle to a neutral shin angle. We are not trying to push the knee super far forward. An exercise like a rear foot elevated split squat is really good at getting that positive shin angle. So remember, negative shin angle to neutral. That's the goal here. So how it is you'll put one foot up and then the arms are going to come forward. So there's that slight protraction moment. We're making sure that we don't put them super far, that they have to start to extend and feed their old pattern, right? So they might feel like they're a little short. The back foot's completely up. I feel myself getting pushed back, and then I'm starting with this negative shin angle. You see how this knee is slightly back compared to the ankle. From here, all we're doing is pushing that forward to that mid or neutral shin angle and pushing it back. So we're purposely staying in this neutral and negative shin angle. From here, we're going to breathe. Inhale, exhale. And as they go through this, make sure they're never locking out that knee. It's unlocked. Lastly, we have a heels elevated goblet squat. What's happening here is the center of mass is being biased posteriorly in two ways, the slant board and the goblet position. The slant board does it because when you step on it, you're naturally getting pushed forwards, so the body counteracts that with a slight posterior pelvic tilt, pushing the center of mass back. The goblet position, or any anterior load position, is going to also start to shift you back. From here, what we're trying to make sure that they do is push the knees forwards as they sit relatively straight down. Again, don't let them shift forward. Don't let them arch and hinge. The anterior pelvic tilt is biased towards wanting to hinge. So what we're trying to really focus on, sit straight down as the knees go forward. Just work where they can move through as far as their range of motion. They don't have to get super low, but they do need to be able to dissociate the knees and stay back as they go down. So I hope you found this video valuable and walk away with a little bit of a different approach when it comes to fixing the source of tight calves. Now I do want to make a quick disclaimer, and that is that stretching is okay. What is not okay is when we have the intent of solving the true problem and then the execution is a stretch. Stretching feels good, will probably get the patient to move a little better, but just know at the end of the day that your execution should always align with your intent. So although I said don't stretch, if the intent is to increase blood flow, get the person just moving a little bit, stretching's totally fine. But if the intent is to solve the source of tight calves, that's when stretching wouldn't be the most ideal option.